For our third session of day 3 of the Covering Rare Diseases Fellowship, we'll analyze a phrase that's heard often in the global health sphere. The term social determinants of health has been used so often in recent decades that it can sometimes seem like little more than a cliched foundation speak term. But in the realm of rare disease, where decades of elusive research can culminate in astronomically priced treatments that only a handful of people can afford, why is it important for journalists to understand what the social determinants of health mean? We're privileged today to hear from two people who have powerful personal stories of navigating the rare disease realm, but who can also help journalists understand how to analyze the intersection between biotech and innovation and the social determinants of health. As we've learned from some previous conversations this week, these two speakers' stories will help drive home the importance of lived experience in our reporting. Sika Dunyoh is Director of Patient Advocacy at Travere Therapeutics. In her role, she's responsible for developing and maintaining meaningful relationships with patient advocacy organizations and the communities they serve. She's also leading the development of initiatives to address diversity, equity, and inclusion in the rare disease community. And before Travere, Sika was director of the education programs at the National Organization for Rare Disorders, which we heard from earlier this week. She developed and managed programs designed to educate patients and caregivers. And these programs included the NORD Annual Breakthrough Summit, which I attended recently and got to meet Sika there. We'll also be hearing from Sarita Edwards. She's the CEO and president at the E.We Foundation, a global healthcare advocacy organization with a compelling and profoundly moving start in this space. Sarita began her efforts of advocacy and public policy after her fifth child, Elijah, was diagnosed in utero with a rare disease named Edwards syndrome, or complete trisomy 18. Sarita is an award-winning advocate and host of the Being Rare podcast, and she serves on executive boards and advisory councils within her home state of Alabama and across the country. Sika and Sarita, thank you both very much for joining us today.
Thanks for the invitation.
Thank you.
So, Sika, I wanted you to get us started by sharing what caused you to make your pivot from the sort of research and advocacy realm to sort of transferring that energy to a pharmaceutical company.
So thank you for asking. And again, thanks for the invitation today. This is actually my second career pivot. So I worked for almost 15 years in marketing. I marketed books and academic research journals my entire career. I was a communications and PR major, and graduated and jumped right into marketing. My sister and I were 2 years apart, and we were extremely close. She was my best friend, and I oftentimes call her my soulmate. Unexpectedly, she became ill when she was 22. She had a number of different symptoms, including pain all over the body. She developed severe breathing issues. She was diagnosed with asthma. She was given an inhaler. That didn't really work. She was still back and forth in the hospital. Her voice started changing. It grew deeper. And so eventually she was diagnosed with something called vocal cord dysfunction, and they told her she should go to speech therapy for that to help repair her vocal cords. But that clearly wasn't it either, because her breathing just continued to get worse and worse. And I remember there was a time, a night I spent the night at her place, and it had gotten so bad that I was scared to go to sleep, because I was worried that she, you know, would not wake up. Um, Eventually, they decided to go in and do surgery and figure out what was going on. And immediately, she was diagnosed with a rare disease where your body attacks your own cartilage. And there's cartilage all over your body, including your trachea. And by the time she was diagnosed, her trachea had collapsed on itself. There was no cartilage there holding it open. And so that diagnosis greatly impacted our family. She was the baby of the family, and we were all stunned. A rare disease, you just don't think that that's ever going to enter your vocabulary. And she navigated the healthcare system after a long diagnostic odyssey. And it was a challenge for her. And unfortunately, a year and a half after her diagnosis, she passed away unexpectedly. So obviously that left a huge hole in my life and my family's life. And then 8 years later in 2015, I thought, God, I wish I had done something meaningful in her memory. So I decided to start fundraising for the National Organization for Rare Disorders in her memory. And that was an amazing experience. I met so many people in the rare disease space. Got to tell my sister's story, and I was changed. And I decided I wanted to work in rare diseases. And so the opportunity presented itself for me to work at Nord. And so I took the big scary leap and left my long career in marketing and went to Nord and did some amazing work. I got to work with patients and caregivers and develop resources that really help them in their day-to-day lives. As Rachel said, I got to develop the programming for the Nord Summit, which is Nord's big premier meeting of the year. And at one of the Nord meetings, I met my now boss. And, you know, I had to think about it. I said, do I see myself going to biotech? It never occurred to me. When I, decided to enter the rare disease space, in my mind, I always thought it's a nonprofit job, right? And so when Eve told me that there was a role coming up, I had to really weigh that. I talked to a lot of people. I did a ton of research. And where I came down to it is a couple things. Everyone I met at Travere was extremely authentic about their mission to serve patients. And there are a lot of people at Travere that are personally impacted by rare diseases. People are patients themselves. There are a number of people who've lost family members like myself. And I think that changes the personality of a company when you're really in the cause yourself. And then also, I think it's important that there are advocates, passionate advocates in every part of the rare disease landscape. So I think it's important that there are passionate people in patient advocacy organizations, there are passionate people in the healthcare space, and there are passionate people in biotech and government, because all of these entities impact the journey of a rare disease patient. And so I decided to, give myself a chance and give this side of things a try. And I feel like I still get to do the important work that advocacy entails doing it.
Before I go to Sarita, I want to ask you if you would mind sort of sharing with us some of those concerns, as frankly as you feel like you can be, about some of the stereotypes and some of the things that we all hear about big pharma these days. And, the bottom line is still the bottom line. Companies want to make a profit. But how did you sort of work through each of those individual sort of concerns about whether I'll be pulled away from advocacy or I'll be pulled away from helping people. Can you share some insights on that?
Yeah, I mean, I definitely had to really even think about my feelings and relationships or relationship towards the biotech industry. And I hadn't thought much about it before. And so I had to think about, is this a place I could see myself? What are my personal feelings about the industry? And the rare disease community, only 10% of the diseases have an FDA approved treatment. And so when you think about that and you think about the loss of hope that many of these disease communities have in not having a treatment available, I thought to myself, it's important that biotech is driving innovation for rare diseases, and to be able to go to a company 100% focused on rare diseases. Our company doesn't work in common diseases at all. I think it's important that there are biotechs out there committed to this particular community that's already marginalized. I mean, you have to imagine most of the healthcare system doesn't understand these diseases, have never heard of these diseases, don't know how to treat them. And so there's already a major hurdle that these communities face. And so when biotech is interested, I think it's important that those companies are given the space to pop up. And then I think Travere is a small biotech company. We're not big pharma, and so I think that also changes the personality of an organization, and so it made Travere feel very much like home for me, in the same way that Nord did.
I have to say, another thing I noticed from attending the summit is one of the things I suspect is part of what's going on is that so many of the researchers and the administrators and people in many of these biotech companies have personal stories of rare disease. That's what's driving them. That's what's fueling them. And that makes it a little bit different than the average commercial proposition. But now for Sarita, what I'd like for you to do is introduce us to you and bring us up to the point in your journey where rare disease entered into your consciousness and where you had to confront it.
Thank you so much, Rachel. And again, thank you for the invitation to be a part of today's conversation. Um, Rare disease met us in 2016. My husband and I, we learned that we were pregnant with our fifth child, and around 22 weeks, the doctors uncovered some unusual anomalies, and they sent us to maternal fetal medicine, who confirmed that our unborn child had a rare disease called Edwards syndrome. They told us, do not Google search it, and that we should find a support group. And that was the extent of the conversation. And so, of course, immediately after the appointment, I went straight to Google and really started trying to understand what this was. At the time, we did not know that it was a rare disease. They did not use that specific language. They just said that it looked like Edwards syndrome. And so we began to just kind of do our own research to learn more about it. We did try to Google support groups for this disease, and we really just tried to learn what it meant, what it was going to mean for our family. Again, it was our fifth child, and so having had four other children prior to this pregnancy, we knew what to expect in terms of prenatal care, the delivery process, and all the likes. Our OB team, they told us that our unborn child would probably pass away in utero during the delivery process or shortly after birth. And my prenatal visits became kind of an assessment to see if he was still living. Every single visit, it was just like pulling the scab off of a wound that was trying to heal. And so in 2017, March of 2017, our son Elijah was born alive. Because of the high mortality rate of this disease, we were denied confirmation testing. We were told that newborn screening wasn't necessary. We were really fighting the healthcare system for routine prenatal and post-delivery services that we had experienced with our other kids. And we were just continually told to enjoy our time because he would pass away soon. And so we were sent home in hospice care where we stayed for 6.5 months, right at 7 months, and until Elijah aged out. And it was in that moment that we began to just kind of coordinate his care. My professional background before crossing over into the nonprofit rare disease space was in healthcare operations and leadership. And so I was familiar with medical jargon and the medical terminology, and I began to just sift through his medical records and look for anything that sounded familiar or seemed familiar. And I began to just call specialists on the phone and ask for appointments. We were told that it was going to be a conflict with our insurance company because we were pursuing life-sustaining treatment options versus our medical team had placed us in hospice care. And so we had to make a choice. We were either going to stay in hospice or we were going to try to navigate this thing ourselves. And so we chose to navigate it ourselves. When Elijah turned 2 years old, that's when we decided to start a foundation. The goal initially was to create some level of bereavement support because that was the narrative that we continued to have. We wanted to remove the burden of a family having to bury their newborn. But Elijah continued to live, and he honestly just became the blueprint of our foundation. And we knew one of the best way to provide the level of support that we wanted to for families, it just made sense to start a foundation rather than try to attempt those efforts as just a family. And so we continued to expand and grow, and we crossed over into the rare disease space and began to just network and build relationships and provide resources and support, and the organization continued to grow and provide resources and support. Today Elijah is 6 years old. He's in first grade. We do have about 19-20 specialists that we have to commute 2 hours one way to see, but he's alive. And we were I think we thought we were just parents fighting a healthcare system because of a rare diagnosis, but we later learned that we were advocating, and we just didn't know that that was advocacy. We were trying to change the narrative about a diagnosis and how the healthcare system wanted to respond to us with it. And so here we are, 6 years later with our little boy, and 4 years later with an organization that now provides resources and support to families all over the world. And so we're really, really grateful. But it was an unexpected journey for sure.
I think these two powerful examples of what has motivated our two speakers to move into this space leads us to a point where it'll be good if we can get a baseline definition from both of you on what you see as the social or the components of the social determinants of health. And I'll start us off by saying that I think the number one component is education or access to information. Sika, would you agree with that? And would you give us some insight into what are some of the other aspects of the social determinants of health from your perspective?
Yeah, absolutely. I think education is key, or access to education is a huge component. I think that people who are more educated are able to access particular resources, whether it's on their own or through their networks, in a way that many other people are unable. I think some of the other ones are location. I think we hear and see that a lot of people in rural communities may have challenges, especially in the rare disease space, where a lot of the major centers of excellence are located on the East Coast or in major metropolitan areas like Boston and DC. You think of people that are in the middle of America who have a longer journey to even get a diagnosis. I think location can't be overlooked. And then, even in urban centers, you have some areas in which there are not healthy food options available to take care of yourselves properly. You have food deserts in some cities. And so I think access to food, your location, education, you know, income, obviously, I think all really do play into how long you live and how well you can take care of yourself. And so with certain communities having limited access to some of these things, and then you compound that with having a rare disease, it can be extremely challenging.
Sarita, what's your take on some of the additional components of the social determinants of health besides access to information?
I think I have to agree that I think education is a critical um, piece of it. I do think that a lot of times, especially in the rare disease space, when there is limited information about a disease or condition that a family has been newly diagnosed with, families are forced to try to figure out information that they should be receiving from from their healthcare team. And I think one of the challenges is a lot of families, from a landscape of health literacy or from the lens of health literacy, a lot of families struggle with understanding what that means, even if they are able to find something. And I think there is a burden of responsibility that we place on families to uncover resources and support that may be available for their particular disease group. And they are burdened with the responsibility to know what to look for, how to ask for it, how to find it. And I think, I just honestly think that it's unfair. I think that the healthcare space they have leverage on a lot of this information, even if they are not 100% certain themselves on how to navigate it, because again, it is a rare disease. And a lot of times the healthcare space they haven't treated a lot of patients with these conditions themselves. But I do think they still have leverage on finding resources and support that they aren't always helping families find and navigate. I also, I think Sika mentioned income. I think that that's a critical piece, for families in terms of the ability to commute to a hospital, that may not be in their community. I think, you know, you know, in a lot of times in the rare disease space, we are a family that went from two incomes to one. And so just really the financial impact of having to navigate your family dynamic within the household, all the shifts that comes with the diagnosis, I think we have to consider. You go quickly from two incomes to a life that you're used to now one income with this new dynamic that you have no idea what it's going to financially do for your home. And it's little things that I think we overlook or take for granted, and we don't always consider what that means for a family dynamic. And so I think those are the two critical ones for me: education and the income piece.
I have to invoke yet another one, which I mentioned during our prep call, and that might be race, skin color, ethnic background. And I'll refresh the journalist's memory by talking about some of the comments that Victoria Gray made on Monday. And I think I shared with Sika and Sarita, the most powerful one was when Victoria said, if in the middle of the night in a pain episode, just so fatigued and tired of being in pain so often and so much, needing to get to the hospital, but then realizing I better have my hair combed and I better try to pull on some clothing that is presentable, because I know that if I go into the hospital looking like this, I'm going to be dismissed, mistreated, talked down to, uh, have a bad experience. And then, of course, you will all remember that she also talked about having a staffer basically do an experiment on her by giving her a medication that wasn't prescribed to her, and they had no idea how it would affect her. And when she called them on it, they just said, "Oh, she didn't mean any harm by it, and you should just let it go." So I'll ask Sarita what I asked her the other day, which was, when you entered your diagnostic journey and were essentially told that, you should just give up, he's not going to live and whatever, do you feel that race played a part of the way you interface with doctors at that point?
I do. Um, I think because of the high mortality rate of the diagnosis, they were giving us the facts. They were giving us the science, and I think they were expecting us to take it at face value because they said this is what it is. Um, I think race played a part when we began to push back and ask for alternative solutions for our son. We acknowledged that we understood this is the science. We understood that these are the statistics. Only 5 to 10% will live past their first birthday, and we were just 2 days old at the time. Like we understood that our challenge was not lack of understanding, and we felt like that's how we were being treated, as if we were not comprehending what they were trying to convey to us. And that was not the issue. We just wanted to have a conversation about an alternative solution. Is this the only thing we can do for our son? And it even went so far as one of the physicians told us that, we can document in your medical record that this wasn't medically necessary and your insurance won't pay. And you know, finances was not a priority at that time. That was not something that we considered. That wasn't the greatest concern. The concern was looking for health solutions for our child who was born alive, who they told us wouldn't be. And so for us, we were trying to figure out, okay, so he was born, he's alive, what's next? And so we felt like we were being treated as if we had um limited comprehension of what they were trying to tell us. We felt like they were treating us as if we were ignorant. um
Didn't you say there was also an example of another white family, a couple? Tell us about that.
there was, we did later learn, and I even met and had a conversation with a mother who, a white family. She actually had a daughter with the exact same diagnosis within a year of our experience at the exact same hospital, and she had a completely different outcome. Her daughter was actually trached, and a G tube was placed before they left the hospital. That was not something that we had to have, yet we were sent home in hospice, and she was sent home with early intervention and resources. And so we did not connect for me to compare our stories, But because someone connected us, and I learned that we were literally within 1 year of each other, 1 year and 1 month. I wanted to know her experience, and I was very shocked and taken aback that she had a completely different experience as me. She did also share with me that that she was a scientist, and they knew that she was a scientist at the hospital because she had done some work with them. Um, and I found that interesting because, neither myself or my husband are scientists, but we both are educated and college graduates. And so I found it very interesting that she made that reference in our conversation, that she knows that they knew who she was. Um, but two completely different instances in terms of how care was provided to us. And so, if full disclosure, I don't think we considered race initially as a factor. I think we thought it was just the diagnosis, but it wasn't until we began to sift through his medical records and see things documented that weren't accurate, or they didn't happen, that we began to just kind of uncover they were just kind of pushing us to the side here. My husband had to ask them to clean him off after he was born, and he was born with bilateral cleft lip and palate. I had to ask for formula to feed him, and we overheard nurses saying, "Mom wants to feed him." And I did. I mean, I had nursed and all of my other children, and I couldn't get it to work for him because of the cleft. Um, and so I did ask for formula. And honestly, I was shocked that I had to, that it wasn't offered because he was born and probably hungry. So yeah.
I have to jump in and just share quickly an experience I had as a journalist when I was doing a story about maternal mortality for National Geographic. And I won't say the name of the hospital, but it was a hospital nearby. And I was in the labor and maternity ward, and there was a young African American mother who I had been following and interviewing in one bed, and a young white woman in the other bed. And I saw the team of midwives, nurses, whatever, come in, and they stood around the young white girl's bed and stroked her hair and talked to her and how are you doing and checked her tummy and whatever, and literally turned around, looked at the black woman, sort of pulled the blanket up and she's all right, and just turned and walked out. They had no idea, obviously, that I was a reporter with National Geographic, but it was so in my face in a way that even after having had been a journalist for 30 some odd years, it just blew me away. It was so obvious at that point. But I want to shift back to Sika, because you have an experience as Ghanaian American. Your parents or grandparents were born in Ghana, is that correct?
My parents, yes.
Yeah. So talk about that aspect of this issue as well.
Yeah, before I jump in there, just piggybacking off of what you both shared, my sister had a job, not the greatest job. She was 22, right? Taking a break from college. She was working at a call center, so she had insurance while she was navigating her diagnosis. But once she was diagnosed, she was put on very high dose steroids. She was put on immunosuppressants because this was an autoimmune disease. She could no longer work. And so she went from being insured to being uninsured. At that time, there was no ACA, there was no Universal Health Care or Affordable Care Act. So she was uninsured. And so, we didn't have the means to support her care in any way. And so oftentimes she had to see doctors who were willing to see her, not knowing when they would get paid, if at all. And so on those few occasions where she was seeing doctors who were willing to see her, she didn't always have good experiences. I remember one of her doctors, she had a visit and my sister was a tough cookie. I was the crybaby. She was the strong one. So I remember this one time my sister was hysterical. She had a bad visit with this particular doctor, and she was like, I don't want to go back. I don't want to go by myself. And I had never seen her like that before. I didn't know how to process this, but she refused to go by herself. She needed someone to go with her. And I have to wonder if her experience was because she was a young Black woman, navigating this, by herself, or if, this was just the doctor's demeanor. It makes you question, when you're a person of color and you have bad experiences in the healthcare system, if it's because of your race or if it's because it's just a bad day.
I want to quickly, before you move forward, just jump in and remind the journalists of one other thing Victoria Grace said, and that was after those just repeated negative experiences she had, she said that if her doctor, the doctor or the person who had told her about CRISPR therapy and promised her or assured her that it could give her a very good chance of ending her suffering, if they had been from one of those facilities where she had been mistreated, she would have turned it down, dismissed it automatically. She wouldn't want anything to do with it based on the way she had been treated. So she could go ahead with.
Yeah. So, my parents are from Ghana. And so, culturally, there is kind of a mindset where, doctors are, that's the job my parents wanted me to have. Okay. There's a reverence of people that work in the healthcare system, especially doctors. And so, when we talk about kind of health outcomes, I oftentimes think about my parents' experiences, which are oftentimes, not to ask questions, not to question the doctor, not to seek a second opinion, because they just have an innate trust of doctors. And so I think that, when we look at, different communities, we're not all a monolith, right? You have to look at people's cultural background and look at how that may impact their access to health, to better health, because I think that there's a lot that can play a role in your health outcomes as it relates to where you're from and your cultural relationship to the healthcare system.
Let's hear from Rupsha Chakraborty of India. She has a question.
Hi. In India, when we talk about rare diseases, often the girl children are being ignored, especially because of the fear of stigmatization. Then the doctors and the patient advocates have to counsel the family members so that they come forward for the treatment of the girl children. So, in your experience, have you also experienced such kind of gender discrimination where the parents refuse to come out for the treatment of the girls? And if yes, what do you do in such situations?
I
Well,
haven't. Oh, sorry.
go
Someone.
ahead. Go ahead, Shika.
Oh, okay. I was going to say I haven't seen that. I think that there are some other challenges around gender that come up in the U.S. around healthcare and access to healthcare. For example, there are instances in which if a woman speaks up about pain, or she's concerned about something, she's considered, just being emotional, because she's a woman. Whereas if a man were to complain about the same thing, he would be taken more seriously. But I haven't seen or heard of scenarios in which, because the child is a certain gender, that their family won't get them treated. I don't know, Sarita, if you are familiar with situations like that.
I was actually just going to share. I think that's why we pushed as hard as we did, because we do know that statistically, boys with our son's disease are at a higher risk um, of death and not surviving. And having the conversation with the family, they were not only a white family, their child was a girl, and we did consider if, because statistically girls have a better prognosis, she received treatment and our son did not. Like, we considered all of that. So a little different than the example that you're describing, but similar in the sense, we think that there was some gender bias because of statistics. But we did consider that our son was dismissed, if you will, because he was a boy, compared to her daughter, in terms of statistics and what the outcomes were. So wanted to just share that.
I'm sure that
And
was, in fact, an important question because, again, having lived in East Africa for 10 years myself, I am aware of the incredible impact of uh, the
Yeah,
patriarchy
because
is.
yeah,
And
because in rare disease it takes a lot of time and also monetary involvement. So I know families who don't want to invest their savings or their energy for the treatment of their girl children. So they prefer investing the money for their sons who have the similar disease.
yeah, you if you have not done stories on that, you should definitely highlight that because that's an important.
absolutely.
Shika, were you going to say something?
No, this conversation did strike up a thought around the fact that some diseases, some rare genetic diseases are inherited from the mother to the son. And so the mother is not impacted by the disease, but when it's passed down to the son, he is impacted. So I believe hemophilia, for example, certain types of hemophilia have that pattern. And so it's believed that even though, the mother may not necessarily carry the disease to the extent that the son might have, but that there are symptoms that she still may have that impact her day-to-day life. And so there are groups out there that support female carriers that believe that they are too impacted by the disease, but because of the way the healthcare industry treats these diseases, it's not believed that they are impacted in any way. And so, that just gave me, another thought about a part of the rare disease experience where women are sort of fighting for their voice to be heard about what they're experiencing, but the healthcare system is not listening.
Let's hear from Manuela Calari of Italy.
Hi, thank you, Rachel. I wanted to ask, how do you feel about, a white person like me, so who, operates from a privileged status, telling those kinds of stories?
An interesting question. For me personally, in the past decade specifically, I've sat in many newsrooms and had many conversations around the issue of lived experience. And some people say it's important to have those voices at the table. Others say, as long as the intention of the person doing the reporting is fine and they're a good human being or whatever, it shouldn't be factored in. I have my own personal opinions about that, but what do either of you have to say?
You know, for me, I think your story is your story. Um, I think I can hear your story and I can respect your story. Um, and even if it sounds like mine, I'm closely similar to identical. I will probably still wonder if race played a part in the decisions that were given to me. Um, Only because more often than not, in a lot of instances, bias, implicit bias, conscious bias, it is ever so present for families of color. And it does not dismiss anyone else's experience, but it also doesn't diminish the fact that I am aware that my skin color impacts how people choose to treat and respond to me. Um,
So, yeah.
no, I'm sorry, go ahead.
So I think what I meant is me telling your story. So I'm a journalist. So as a
Oh,
journalist, I feel I really want to tell these stories because I feel they are important and people need to know. But on the other side, I feel, well, maybe I'm not the right person to do that because I don't have that. Well, I might have some experience in, gender discrimination and things like that, but I definitely don't have the lived experience of having a darker skin. Um, so I have this conflict in me and in saying, well, I'm a journalist, this is my job, I'll do it, and
mhm.
say, well, maybe I'm not the right person to do this.
Oh, well, now in that regard, I completely misunderstood your question. In that regard, you are the right person. I think if there is an opportunity for you to share a story like the one myself and Shika have shared, I think you should totally do that. And not just because it's us, but because there's opportunity to highlight inequity and disparity that exists in healthcare systems. I think a lot of times, because of how you've described yourself as a white person of privilege, I think a lot of times there is that internal conflict on, am I the person to share it? But I think when it comes to sharing stories like these, we are looking for opportunities to raise awareness about the disparities so we can dismantle it. And so having people willing to have those hard conversations like the one today, I tremendously applaud Rachel and her team for making sure we could share these stories today because it's a difficult conversation. But I think we have to move past the surface level of conversations about inequities and disparity and social determinants and really get to the root cause of what it is. And we can only do that if more and more people are talking about it. So for me, it's not about you sharing my story. It's about you sharing a story about inequity and injustice and disparities that needs to be highlighted. So I would say do it for sure.
Yeah,
That's a
I was
brilliant
going
answer.
to second that and say I think that given your position of privilege, I think there's you could see it as an additional responsibility that you carry to tell the stories of a diverse range of people, right? And not just white people. I think that have a really blessed position where you have an opportunity to show the range of lived experiences. I think what you could do is to build in a regular check-in with yourself about the intentionality behind the work that you're doing. Because I think that what could happen is when you're not checking in with yourself, the intention of what you were originally trying to do gets lost, and then I think that's where those bad feelings could come in. So my advice to you is please tell our stories and always check in with yourself about your intention, for why you're doing it.
I'm going to ask Pascalina to jump on. Shika, you answered her question, but I'd like Pascaline put that question to Sarita as well. Pascaline is from Lesotho, by the way.
Thank you both for sharing your stories. Really inspired by how brave you both are. My question is that as journalists, sometimes we go and interview people and we find it really hard to be empathetic. So I was wondering if there is one most important advice that you can give to us, perhaps on the do's and the don'ts of what we should do as we go about interviewing parents, in fact, patients and families of the rare diseases patients. Thank you very much.
Thank you. I think for me, when you are having a conversation with a family, with a patient, with a parent, a caregiver, whomever, I think you should always go in with no assumptions. I don't think it's ridiculous to not be able to empathize, depending on your own experience and where you are in your life. I recognize that everybody can't relate or have empathy for the experiences that we've had. But I do believe that in having a conversation, you can approach it from a clean slate and walk into the conversation with no preset thoughts or judgments about what I might say. I think sometimes we miss really good conversation and opportunity for dialogue because we have already convinced ourselves of the outcome before the conversation has ever even started. But I think if you walk in with just a clear conscience of what are you trying to gain from this conversation, I think you can have a good conversation. I'm a huge component, a huge champion, a huge advocate for removing assumptions. Just don't assume you know anything. Even if you've done some research ahead of time, walk in with a clean slate. That way you have no preset thoughts or judgments about anything that might be shared.
Let's take one more from Rupsha.
Hi. In India, I know many patient advocates who are very close to me on a daily basis. We interact. But like being a patient advocate, you have to deal with patients and their life-saving needs on a daily basis. So, on a personal level, how do you deal with the emotional weight on a daily basis? Because I'm sure listening to their cries or their need for help, it also has its own emotional weight. So, how do you deal when you go back home? How do you deal with it? It's a very personal question, but I just wanted to know because being patient advocate also comes with emotional weight.
I'm smiling because I remember when I started doing rare disease fundraising for rare diseases. I would have like a table outside of an ice cream shop, and I was asking people to donate. I mean, that's as basic as the kind of fundraising I was doing at the time. And I remember people would see the sign in front of the table that said rare diseases, and people would come up to me and open up and say, my uncle has a rare disease, and they would start getting emotional with me. And I remember being very sort of, oh my God, I'm not prepared to deal with this, right? I was scared to hear people's stories and to have them open up to me. I think that, now in my work, it's something that I welcome. Because I feel like if people see me as someone that they can approach, it means I'm doing my job well. I want people to see me as a soft place to land, so that if they do want to open up, they feel comfortable because of the way that I've treated them, the way that I have opened up to them. And so I understand how it could feel uncomfortable. But I think that, over time, you're going to start to understand that if people actually feel comfortable telling your story or their story, you're doing your job well, right? So I don't know, Sarita, if you have more to add to that.
I do, and I think it goes back to what you were saying about intentionality. I think just really, really being honest with yourself about your intentions, and I believe that it can become a heavy burden to just the redundancy of the tears and the crying.
Yes.
But I think if you really kind of assess and, you know, again, not assume what they're crying for, because they could be crying because the story is sad or their loved one passed away. They could be crying because they're frustrated. Like it could be angry tears because I'm sick of having to fight insurance providers and healthcare systems, and just not assume that the tears are always sadness. I think um, we have to remove the pity that we put on people when we see them cry, because we don't know what they're crying for. I think that's an opportunity to ask, because I'm not afraid to say to someone, what are those tears about? If they're open to sharing that, they will tell you what they're crying for. I have cried in an interview, but I took the opportunity to share that, these are tears of celebration because I know where we once were versus where we are now with my son. So these are tears of gratefulness. And so I think it's just removing the assumption of what they're crying for in the first place. But I do totally think if you continue to just, like Shika said earlier, check in with yourself um, about why you're doing it, and then ask yourself, why why am I affected by someone else's tears? Like, what is that doing to me? Is it because I'm sick of seeing people cry? Is it because it's pulling, some level of compassion within me? Just check in with yourself about why does it even matter to you that you feel when they cry, and then assess what those feelings are.
I think we have time for one more question, and that would be from Karen Weintraub of USA Today.
Hi, thank you both. Sarita, I have a question shifting gears. Your story, in a way, is a warning to us. We tend to talk about these early signs, the signs that these tests, these children are going to have problems as a great thing, that we're learning. We know what to do. We can highlight these problems. And yet your story is about learning about these problems can actually be a downside, or at least can be defeatist in some ways. Do you think that we need to be more careful when we write about the wonders of pre-implantation genetics or about early diagnosis, and be more careful about how we report these things?
Yes. I think we have to be careful in, making generalized statements about different processes, and how they may relate to everything. I think if there's opportunity to highlight something, of course, do so, but isolate it to whatever that topic is, and not make broad statements to make it appear as if it applies to everything. I think learning early about our son's diagnosis, it was a great thing for us. It was the response that we received from the healthcare system that made it a bad experience for us. It was more so their knowing that it was present. It shifted how they provided care and how they choose to respond to the diagnosis prenatally and post-delivery. I don't necessarily think it shifted our approach to care. We continued along the path of pregnancy like we had with the 4 other children previously. And so I think if covering stories specific to prenatal implantation or prenatal treatment. I know that there are some talks about things that can be done prenatally for embryos that that can create better health outcomes once those babies are born. I think it's for sure okay to cover that. I think we just have to be careful in how we frame um, those words, and just not make it assume that it applies to every scenario. I think if there's room to be as specific as possible, maybe give some examples, we should do that. Because it's not the same for every person. It definitely wasn't for me.
I think journalist Santiago Nguyen of Vietnam has provided us with the absolute ultimate best way to end this conversation. He says it's good to have empathy. If we don't have that ability, though, we can still do our duty as journalists to reflect stories accurately and fairly. This conversation is so meaningful to me because I think it just totally encompasses everything we've been talking about over the past few days about this sort of inflection point we're at in history with technology and innovation and the possibilities. But if a large group of people are still left out of access to those possibilities, what kind of a drain is it having on the world, really, but certainly in the health equity and the rare disease space? So I want to take this opportunity for us all to thank Sika Dunyoh of Travere Therapeutics and Sarita Edwards of the E.We Foundation for a profoundly provocative and evocative and important conversation about the social determinants of health. Thank you both so much for joining us.
Thank
Thank you
you.
for the invitation, and thank you guys, journalists, for listening.
Thank you.